Thanks a lot for joining in. This is the first panel which we are having, the future of EHR in India, challenges and opportunities, in the second edition of Healthcare Transformation Summit. I would like to thank each one of the panelists who have actually, Mr. Vineet is from Dubai, who has joined as well. So I would like to formally invite you all to the panel. Mr. Arvind Sivaramakrishnan, Group CIO of Apollo Hospitals, Mr. Girish Kapoor, General Manager, IT Wocar Hospitals, Mr. Prashant Singh, CIO, Max and DLK Hospitals. Mr. Vin Purushottam, CIO, Aster DM Healthcare, and Ms. Vinu Williams, CIO, Health Transformations, HN Reliance Foundation Hospital. Thanks a lot for sharing the dice and for coming in and talk about an important aspect here. The moderation of this session would be Mr. Girish Kupar. So I'm handing over the session to Mr. Girish. Over to you, Mr. Girish. You need to unmute yourself. Yeah.
Yeah, thanks, Pratibha, for the opportunity and a very big good morning to my fellow panelists. I think the panelists don't need any introduction, actually. They're all quite well known. So, as the topic is future of EHR challenges and opportunities, we'll start with Arvind, who's himself an encyclopedia for EHR. So, Arvind, can you just explain what is EHR and if there are any standards? And we can just start with so that the audience are aware of what EHR is and if there are any standards and where are we in terms of that.
Perfect. Thank you, Girish. Good morning and namaste to everybody. Definitely, I think the words that are commonly used are EHR, EMR, and PHR. And unfortunately or fortunately, they are used interoperably. So, very typically, if you go by very strict definition terms, the electronic medical record is the record that happens within a health system. And the electronic health record is the combinational longitudinal record of the patient across health systems. And the PHR is that component of the patient health record that is with the patient. So what's the difference here? There will be part of the health system's records that are not always given to the patient, typically like a nursing note or something, which is part of the health system's care process. And not all these are handed over as patient deliverables or patient care continuity records to the patient for next steps. So subtle difference, and it's not about the nuances of this difference, but overall, the crux of all of this is seamless longitudinal care record across care setting so that no health information is lost when a patient is going through various treatments and when a provider is seeing the patient so that they should not miss anything. That's the whole purpose of EMR, EHR, PHR, whichever connotation we want to go through. The moment you do that, I spoke about longitudinal health record care settings. That means that you need to talk in a language that when you move from setting 1 to setting 2, whether it is the same organization or different organization, you are not talking in a different language. You are not talking in a different language so that we are not misrepresenting any state of information. That is the whole idea. This is why there are standards. Yes, there are standards. In India, there is the EMR standards that the Ministry of Health and Family Welfare has put as an advisory. It's not a law. It is an advisory. It is a guideline. And it is, of course, the standards are available on the ministry website. It's gone through about 2 or 3 revisions also. It's a living document. It keeps getting updated so that people use it with the intention of making it constructive. I obviously will not discuss in terms of is it going to become law. I think as far as Indian scenarios are concerned, I think there's quite some time before it is an enforceable law for several problems that we all face across the health ecosystem in our country. But having said that, the guideline is an effective guideline. Internationally, there are several guidelines that allow people to follow best practices. Again, if I can move away from law and legality and all of that and look at what is the right thing to do, there are several guidelines. A not for profit organization in this space is HIMSS, Health Information Management Systems and Society. It's a not for profit public organization that is generally regarded as the gold standard of such like adoption. So they have what is called the EMR adoption model, or in short, it is called MRAM, EMRAM. And it's available at 7 levels of maturity that basically guide an organization of what their digital IT in their operational and clinical standards are there. So in simplistic terms, we have the connotation of what is called a digital hospital. So what is a digital hospital? A digital hospital is something where you're able to effectively demonstrate adoption over the 7 levels of the MRAM maturity. And that 7 levels of maturity automatically talk about what we need to do as an enterprise design, where we need to make the investments, how we need to talk about the care continuum. And this is across the health system. It is not limited to clinical only. So many a times EMR is always associated or thought to be associated with pure clinical. This is all about bringing the whole health system together so that that longitudinal care continuity and the patient's pristine single health record is maintained. So that's really how this whole thing is looked at.
Yeah, so Arvind, if I understand correctly, so this EMR is more of putting everything on a digital platform, maybe clinical, non-clinical, otherwise, which will be helpful for the treatment of the patient, right?
At preferably a living record at point of care and not relegated as a documentation system. It is the source of truth, the living record for every care protocol, so that the patient's care across multi levels of care process, multiple roles of people is seamless. Information flow is seamless, data flow is seamless, and the insights that come out of it enable the right activity at the right time to the right person in the right context in the right format. So making sure that there is no care lapse and thereby driving every level of excellence that is there to drive. So that's, I would say, an EMR is for that. An EMR is not a relegated documentation system to keep.
Okay, fine. That was a great introduction. So you also mentioned that in India there are a lot of guidelines for the CMR, right? So we are still not come out with a policy or the thing, but the guidelines are now quite effectively being followed by good hospitals, so that the care continuum is right. Okay, thank you for that. Now, Vilu, if I can come to you, you have an exposure of working across different hospitals in different cities. Also, some of them are having the old legacy systems, and now where HN is a new hospital and they have the new system. So, what is the difference you see between the new and this greenfield and brownfield typically?
Okay, so older hospitals, which are already existing for a very long time, they are not really that mature in the adoption of EMR as the newer hospitals. They are also using EMR or adopting EMR is more of a mindset within hospitals than anything else. And as Arvind also said, the level of maturity that we create in the hospital, that itself becomes a challenge in many of the hospitals. So if I talk about brownfield hospital, if in case a hospital is existing for say 10 years, 15 years, 20 years, even 50-year-old hospitals, many of them I have worked in, like Jaslok or CK Birla Hospital, the EMR adoption is not that mature because doctors are also very senior, and senior doctors are not very pro digitization. pro EMR adoption, and the use of paper is much more prevalent in all these areas. So that is one thing. If I come to the let's say, for me, HN is not really a greenfield hospital, but it is more of a it conforms to the green building concept, and it is a brownfield hospital which has come up with a completely new structure, a new design, a new format, and it is extremely it's very highly digitized. Digital adoption is very high in Reliance as of today, and we are striving to further ensure that we can maintain this digitization with all levels of specialties and all levels of doctors. So with respect to EMR adoption, I don't think it is anything to do with brownfield or greenfield, but it is more a mental state of in which the hospital functions, where it depends on what level of maturity they want to attain with respect to digitization in general, and with respect to adoption of EMR in particular.
Yeah, thank you. My question was, see, because when you say old hospital, again, EMR is more towards your HIS. And once an hospital has procured an HIS, I think it stays for 10 years minimum. So, because if you see, EMR has come up in the last decade or so. It was there. I'm not debating that it was not there, but it is picked up in the last 10 years. So should it be a part of EMR, the HIS, or should it be a layer? Because the older HIS vendors, they didn't have a mature product, right, to incorporate the EMR, and the cost was too high. So I was coming from that point. HN was a new application, so what was the difference there?
Okay. So, okay, to answer in that respect, EMR is always an integral part of HIS as a whole, or as Arvind mentioned, it is a part of the eHR as a whole. And EMR need not always be a part of HIS as a mandatory requirement, but without that, you can't really digitize the medical or the clinical side of HIS. When we talk about HIS, we basically address more of the administrative qualities of the hospital, where the digitization is towards administrative, towards billing, towards admissions, towards registrations and all this. But when it comes to medical or clinical side, EMR and EMR alone is the most important factor of digitization. So if you want to digitize the hospital as a whole, then yes, EMR is an integral part of it. Now, coming to, let's say, implementing EMR, all right? Implementing EMR is definitely a challenge, as well as it is a mindset, as I said. It is more involving the medical side, and you know already that the medical side, mainly the nurses and the doctors, are not so, I wouldn't say averse to digitization, but they're not so tuned towards using an electronic system, mainly because of certain factors. And we need to understand these factors. If these factors are taken care of, I'm sure EMR can be a success in every single hospital. So I would like to highlight these factors a little bit in order to understand from where EMR adoption can become more successful, or how EMR adoption can become more successful. So first and foremost is that, what is the ease of use of the developed EMR, and how accurate the system is when it comes to utilizing the medical records, the electronic medical records, or creating the electronic medical records. So as against, if you can give a system which is as easy as writing on paper, then obviously everybody would say yes to use it. But that is not really possible in a structured or modular EMR. It's not always that easy. So there are definitely certain constraints which doctors and nurses or the medical fraternity has to get used to, and in that, training becomes also a major part of its success. So when I say accuracy, all right, generally, when they write on paper, they know it is very fast. It is what they have written is in physical copy, so they are responsible and accountable for it. When we are talking about electronic records, we need to also understand that the system has to be accurate enough to create a workflow which the doctor or the nurse can carry forward. Like, for example, if I'm talking about medication, which registration and admission and all that is fine as part of an HIS. But when I'm talking about an admitted patient, let's take the case of an IP patient. The patient starts with a doctor from his progress notes to his medication ordering, to his medication dispensing, to his medication administration, leading on to the entire workflow up to his discharge. Now, how accurate can we make this? How ease of use can we build into this? And how comprehensively we can create that entire workflow makes the entire EMR successful.
Okay, thanks, Vidu, for that. I understand because see, the medical fraternity has other things to do also other than the treatment they are doing. So I think technology has helped them a lot, like your speech to text and other activities. It's a habit they are a bit reluctant to change because their focus is more on patient care than EMRs. I understand because I also have dealt with similar problems, and I think moreover they have understood the benefits of EMR and they are slowly going in the right direction. So Vinit,
Girish, if I can come in just to add to that point, couple of things which I thought is worth mentioning here is that I think it's all about priorities. Okay, whether it is organic growth, inorganic growth that hospitals have gone through, there are hospitals who have decided to switch and use the HIS with an EMR, right, and slowly get at least into a CPOE, at least to get the OP
prescription.
uh, OP modules adopted. So the whole discussion, I believe it's all about priorities. Wherever the priorities are sorted and people have decided, it is possible. Any project, whether it is HIS, EMR, or whatever you do, change management is part of the key. The only place where I kind of tend to disagree with Vilu and many of us is that I don't think it is right that we go trying to change the current process that we are used to doing manually into a computer. Meaning, let us not try to say that it should be as simple as writing piece of paper, because there are a lot of technologies that are brought in, it helps you adopt, but at the end, the change is a change. The change has to be accepted, and the clinicians and the hospital authorities and operators have to learn to use that system. Because if we try to convert our current manual process into a computer process or a system process, it does not help you as much as there is an opportunity that you have in doing such projects to revisit your process, completely optimize it, and change it. So for me, that is one, and I've seen, because in my healthcare experience in India, and then now I'm here, I've seen that in India, an HIS, I always say, is a billing system plus a hotel management system. It is just created to billing as well as manage hotels, the rooms and the beds and the food. The whole focus on using it as an EHR EMR and to capture the patient's records onto it still remains on paper. That's where the recent changes, I believe, will definitely drive adoption.
But I think that should come from, it should be a top-down approach, right? So the
It's
top
a,
management should have the will, only
yeah,
then
it's
it
a, it's a, it's a all across approach. I would not say top down. It's top down, bottom up, everything, left, right, left. It's all across, because it cannot be left to a CIO, it cannot be left to a CMO, it cannot be left to a. It has to be accepted all across.
Okay. Now, since you have hospitals in India and across the UAE also, so what is the difference in mindset you see there, people towards EMR vis-a-vis in India?
I'll put it very simply. Arvind started off saying, right, we have policies, we have advisories, right? there is no mandatory regulation there. Number one. Number two, the markets are like in the GCC and in the Western countries are driven by payers, where the payers, I mean the insurance providers, because 99% of our money comes from insurance providers. Very unlike how we have in India, right? And the payers drive very clear adoptions in a way, either you like it or not, because the submissions are cleared, the money is sent to you. In simple terms, if the entries are right, if it's all matching, if your payer and the network, what you're eligible for is all that you have received. If anything that is excess received is been collected from the patient. Now, if that kind of process has to be put in place, uh, I don't think anybody has a choice but to adopt EMR. Now, here, even there, we also have various degrees of adoption. We could have where the doctor uses the EMR, but before the submission happens, there are coders doing what is typically called as scrubbing, where you actually ensure that there's the right ICT codes and all of that. But the adoption is normal, because without an EMR being adopted, without the patient's uh, the entire subjective, objective, the entire process being followed and the entries being done into a health record digitally, it becomes very difficult for the payers to process the value amount for you. So I believe that drives a lot of adoption. I also believe that I wouldn't say that in India we started. We could have. I'm sure if there was a regulation, or if there was something mandatory, I'm sure there also it will change.
So if I understand you correctly, processes are more set in the UAE than in the hospitals, and it will be easy to implement an EMR there, right?
Girish, wherever there is a payer-led market,
Correct.
wherever the uh, about 90% of majority of your payment comes from insurance providers, and they themselves are large players. They are completely digitized, and they force you to digitize, because you have no choice but to be digitized. There, the adoption becomes a reason for adoption. I'm not saying that is the only reason adoption happens, but yes, that becomes a big reason for adoption, and that then leads to a lot of other advantages that naturally can be coming.
So a seamless integration between your payer and your HIS, it's required, right? For this, it's a very critical so that the data is seamlessly transferred and back. The two-way
It is
communication.
required. It is required, and now one more thing has happened. Just like we have the National Health Registry in India now, most of these, at least I can speak about the GCC, Dubai, as well as Abu Dhabi. Both have created their own health information exchange. So uh, in Abu Dhabi, it's Malafi; in Dubai, it's called Nabid. All these are also means that it is not just the hospital record, but across the hospital, the records are available for a patient's data and his journey.
Okay. Thanks, Will. I think Prashant is waiting for a long time. So let me go to Prashant. Prashant, now you are heading the BLK group and you're acquired Max also. So what is the difference you see between your current organization and acquired in terms of EMR?
Thanks, Girish, for putting me on, and good morning, everyone. So before that, basically, let me tell you about the merger and acquisition first. Actually, as we all know, that merger and acquisition, brings its own challenges, both from the technical and cultural perspective, and one has to really, deep dive and analyze to come to a conclusion that okay, which system needs to be shifted to which side, basically. So that is a big battle, basically.
And
So as in
interoperability between the two systems, right? Again, how will they talk to each other? That is also a
right,
challenge.
right. As in our case, also basically, so we were, on two different technical platforms actually, from all respect, from the technical, from the clinical, non-clinical, ERP, HIS, and everything. There was no single, common system actually which we were using across the organization. So we were differently, on different technical platforms. Now, the best choice actually which I had was, I can pick from best of the both the words basically. So that was the advantage actually which we get. And the challenge actually which we got is, even if something is has been implemented very well in say one single hospital, and we can't really take a call and replace all 14 hospitals just for the sake of this particular change. So that was the challenge actually. So to overcome that particular challenge, what we had to do is basically, rather than changing the entire technical platform, so we had to pick and choose from the best practices, and try to incorporate in the larger ecosystem, rather than changing one 14 hospitals. Actually, it is better to change in one single hospital. So that was a strategy actually which we took on.
Okay.
So yeah, so there are a lot of rollover and changeover had already had happened basically. So we have already rolled out financial systems, business intelligence tools, and all ERP. So now the entire group is on single platform, single instance basically on these kind of platforms. Now we have already embarked on the journey as far as the HIS and EMR is concerned basically. So we are we are in the transition phase from putting the HIS actually which we were using in the Max and in the Radiant hospitals basically. So now coming on to the EMR, for example, if I talk about the adoption specifically in both the groups basically. So in Max actually, if we talk about OPMR, so the adoption is near about 65 to 70%. So when I'm talking about adoption, I'm talking about the use of e-prescription basically, wherein all doctors are actually writing on the e-prescription. So the IPD EMR is near about 80 to 85% for that particular matter, and the Radiant is a little less in terms of adoption of the EMR, but and of course everybody is aware about the challenges as far as the EMR implementation is concerned, in terms of both change management and the fear of productivity loss also. But one thing I just would like to mention here, as a part of advantage actually, which what I'm exactly getting is, so there is a healthy competitiveness within the same group. Now, one hospital is on a different adoption level, the other hospital is on the lower adoption level. So there's a healthy competitiveness actually which is coming across, and I've witnessed many instances there basically, wherein the medical administration specifically is after IT that okay, when are we getting the EMR implemented. So there is a good change actually which is happening across the group basically in terms of rolling over the EMR. And more so basically there are different evidences of the best practices actually which can be shown from one hospital to other hospital, that really encourages the users actually which are on the low adoption as far as the EMR is concerned. So there are many other examples like clinical data which is available for the research that can be showcased to the low adoption hospitals. And there's a continuous quality improvement also actually which can be presented to all the hospital, looking at the competitiveness basically the hospital who is not actually on the low adoption of the EMR actually, which can envisage that okay, if I would use this, I would get this. So that is the kind of incentivization actually which they get, and I'm very hopeful and getting a good response from hospitals.
Thanks, Prashant. Moving back to Arvind, we already have a lot of questions being asked. So, Arvind, my question to you is: in the last 5 years or so, how is the EMR changed in terms of technology, process, and the mindset?
First, if I have to take the question in terms of technology, I think there's
Yeah.
been a huge change from obviously the whole client server aspect of delivery is almost gone. Okay, so everything is web based. And more and more in the last 2 years, it is not only web based but also mobile enabled. I'll be careful not getting into the terminology of app versus not app, but mobility from a perspective of how it can help at point of care. Also, over the last about a year and a half, I'm seeing a lot of trust in terms of usability factors. So the biggest problems in EMR from a design and a technology standpoint was it was very, very click intensive. And obviously, people were uncomfortable typing, and they felt that it was too more administrative versus aligning with processes. So that has led to a lot of better thing usability changes in the whole technology. And to the earlier conversation that Vilu and Vineet were having, that has led to aligning on getting. I think there's an echo on my front. I'm sorry for that. I hope my voice is better now.
Yes.
So,
It's
and in terms of the process activities, so it is about the alignment of the process. It is not about a replication of a current state. Yes, it is a change. There is no denial and it's a change. At the same time, there is enough understanding done on why the existing process that was there in paper was followed and how it can be effectively turned into a digital workflow so that all roles participating in the care process, administrative process, clinical process are very, very effective. So that sort of a process alignment and mapping to the technology has become very, very prevalent. So the whole EMR situation is turning into how can we align? There is better respect for process understanding. So what does that mean? That means that it is not IT fit on process or process fit on IT. It is about how do we bring it together? How do we
Yes.
bring the best of all worlds together? And how do we really make some effective outcomes out of it? This is not one fitting that automatically is turning into better adoption. Again, I'm definitely seeing between the last 4 years and the last about 2 years, I'm not finding today the need to explain to my stakeholders the benefit of the EMR or what it can do for them. I think today the conversation is how, more importantly, how quickly. I think these two are very important. And I cannot sidestep on the issue of how do we make it economically sustainable. I'm not going to bring in words like cheap and low cost and all that. It has to be sustainable because it is now part of the DNA of our care process. It is DNA of our operations. It is no longer a HIS versus an EMR. This is about the health system coming together. And yes, billing is as important as the clinical activity, the nursing activity, the medication administration, and vice versa. There's no question of taking sides on this topic. It is about how to bring it together. It is how to present that information at point of care with complete 360 degrees of awareness. Different roles of people have different perspective of it. So today it is becoming more about how do we do it? How quickly do we do it? You would ask Prashant the question of what is your thought on adoption? It's about, yes, how do we all drink that magic sauce and get to the highest level of maturity? I see a sense of restlessness in people on getting to that maturity, which is a good thing. But at the same time, I don't want everybody to sidestep on necessary aspects of organizational change management. So that's really how technology is contributing. And if I can make a shout out to the software industry, definitely they'll have to do better in terms of helping out on costs so that they are more India economic specific. It really doesn't matter what it comes in the West or what it comes outside India. It's an irrelevant topic. It is all about what is its value in India and how can India sustain it. And how can we make India sustain it as a win-win, not a one-sided conversation.
Yeah, thanks, Arvind. Regarding the mindset, I think you missed that. So, because you see a lot of EMR players coming in, and you have a lot of doctors as a part of the core team. So, how do you see that? Because a lot of these vendors have doctors also in their team where they are launching a product or building a product. I think that is a very good sign, right?
Absolutely. It's a very welcome sign so that these technology players have a solid understanding of the clinical background, the clinical processes, and getting the doctors as advisors into product development and mentors into product development gives that perspective of not only the larger aspect of the EMR, but also the niche area, where be it dialysis or chemotherapy or some aspects of neurosciences, the niche area. So all those, I think, bringing in doctors gets us to understand, respect the nitty-gritty, gets us to understand and respect the points of failure and ensure that we don't step on.
And
Now,
Girish, if I can, come in here basically.
yeah, go ahead,
Sorry.
Prashant. Yeah,
I
go
said
ahead.
lying would not be the good word to use.
On the mindset, and because I've seen with my experience basically, so the if we talk about user friendliness of the software, basically it is a very relative word. Basically, I have seen the adoption of the complex software more as compared to user friendliness in the software actually is being used very on the lower side. And this is we have recently experienced. Now the mindset of the user has also changed now
Correct. If
with
they
the
see the benefits,
and we are looking at the same software with the different eyes now. So
exactly.
that was all.
That was my
Yeah, that,
question. So if the doctors are really seeing the benefits, how much of the mindset is changed? So from that angle, my question was like,
Yeah,
if they are
yeah.
seeing the previous record, previous history of the patient, I think that really helps the doctor in treating the patient, right? Rather than the
right,
patient carrying a baggage of the physical copies.
right,
So if
right.
you can come in, Girish.
That's all.
Yeah. So I guess Girish, it's a simple thing, right? We say what's in it for me. If the
Yeah,
what's in it for me is clear, things work. So there's recent the change in the adoptions is also driven by what's happening around us now, whether it is telemedicine. Because if you have to see your patients digitally, I don't think you can rely on paper. So there is a slow. They soon realize there is a benefit in it. I also see. I also saw the mindset change with some of those enabling technologies or things that came up. No, I'm not saying it is fully there in place, but things that fall under the second opinion category for doctors, where the solutions enable them to make a decision faster, whether it is use of artificial intelligence or whether it is uh, the use of various algorithms. But then that also has helped change a state of mindset to an extent because they have seen that there is a benefit, and wherever there is a benefit, I guess why should anybody not adopt it? Uh, I also see perhaps there is one more aspect to this whole our industry is that the main stakeholders a doctor who is a specialist and who is our main stakeholder has spent so many years in colleges and in studies that when he's here, we are talking about somebody who's done this who studied several decades ago, at least 2 decades ago, right? Uh, Therefore, as and when more and more the new generation comes in, they just like any of us don't even know how to use a paper. We only know how to type better than write fast. So I'm sure there is going to be a change, but that change is going to be little late. So I attribute to a lot of these things but I definitely agree that mindset is changing big time, and in big way.
I think Vineet, you missed out one this thing. See, mindset will change once you see the benefits, and second is the ease of use. How easy is it the application to be used? Because I thought we'll not discuss about COVID, but unfortunately, one point I would discuss this EMR is also at lower levels also because now it has come to B2C also where a lot of GPs and people are starting using. So there are a lot of startups who are mushroomed and they have the application which is helping the GPs to connect to the patient without physically meeting them.
So ease of
I
use is ease of use is a very relative term, Girish, because it's very difficult to define. So for somebody it's very easy to use, somebody it's very difficult to use. So I have seen. So I would still give weightage to what's in it for me more than ease of use, because if I see a what's in it for me, I'll do it hook or crook. If I don't see a what's in it for me, I'll find reasons not to use it.
so that is on the higher priority. Yeah, I agree. So coming back to video, I'll put you a very tough question now. If you want to select an EMR, so what would be your options in selecting a good EMR?
I've got like 100 criteria actually for selecting an EMR.
In
That's
terms of
just an
cost,
exaggeration.
technology,
But
yeah.
let's really, on a serious note, list out at least maybe 10 to 12 key criteria, which goes a long way into adoption as well as other success of an EMR. So though originally Vinit did not agree with me when I said as easy as writing on paper, but what I did not mean at that time was that you don't really convert the paper into an electronic device or electronic system. What I meant was that the time taken that a doctor spends in talking to a patient and filling up an EMR in real time is what is important to the doctor. So generally, when throughout my experience of implementing EMR, the most important question was from the doctor. The most important question was, should I keep writing and filling the EMR or the medication or the progress notes, or should I talk to the patient? Should I look at him? So this has come from an OP consultant in an OPD. It has also come to me from registrars. It has also come to me from senior consultants. So through so many years of working in this space, it has been difficult for me also to answer this question: should I talk to the patient or should I capture the data that we are discussing? So what is this data that needs to be captured is one criticality which we need to understand, and that is where I said the ease of use comes from how much you build into an electronic system and how much of this is in real time and how much of it can be captured later on. Later on meaning today, if I give an EMR system in the hands of a doctor and I say, okay, you first see all your patients, then come back to your table and then start filling up everything, will that really help? That's not really real time. At the same time, the components of EMR make it very difficult to fill everything in real time, yet there are some things that have to go in at the time when the doctor is talking to the patient. So these criteria are very important to look at when we are designing an EMR. Most important, higher than this, is the accuracy. So when we are talking about an EMR, and if supposing I'm talking about a nurse and a doctor's functionality, then whatever a doctor fills up or captures, when it goes to a nurse, it has to go into a very accurate workflow system. When it is seen by the nurse and when the nurse goes into administration, that has to continue with that same level of accuracy. This is a challenge which I've seen across many of the hospitals when it comes to EMR. So when you expect doctors to fill things in real time, they make a lot of mistakes.
I agree with you, Vilu, because the eye contact is missing. That is the most commonest what the doctors say. There is no eye contact when they are using EMR. Yeah. Second thing I wanted on the cost, like how do we justify the ROI? Because see, the EMR doesn't come; it comes at a cost, correct? So whenever you're selecting, how do you justify the cost and the ROI? Because it's a very intangible thing to justify. If your management asks, do you want an X amount? So this is open to all, not only Vilu. Because so how do we justify this? Any takers for this?
Yes, let me just start by with it, and then others can follow. So I do not really see large hospitals like the ones we work in, um, having cost as a factor to decide on EMR. Most important is that it depends on where is the management focus, how much is the focus on digitization, how much is the focus on maintaining the care continuity of the patient without having a lot of paper involved. Digitization helps in many ways. So, and EMR plays a very big role in this digitization. So, when you talk about cost, really, what is it? You are talking about a system if designed and implemented correctly. It really is as expensive as any of the other digitizations that you do across the hospital. In fact, maybe less. If you're looking at another factor or a criteria of EMR, which is accessibility from anywhere, anytime, and also the mobility factor of utilizing EMR, then yes, you can think of a little cost coming into the picture where you build in options where cost is involved. Like if you say that I want to give a tablet in every doctor's hands so that EMR becomes a success across the hospital, then that is the small cost that we look at. If you are looking at you know accessibility anywhere, everywhere, you are building mobility systems, you are building the back end in such a way that you are exposing your systems to be available from wherever the doctor is. So especially as you took the point of COVID, I'm not going into COVID, but if a doctor today does not want to come to the hospital for any reason and yet wants to do a consultation, be it for OPD, be it for a discharge consultation, be it for this, and document that consultation, you need a feature of recording the consultation. You need the feature of a strong, secure network. You need the criteria of a very balanced workflow of the system itself, which defines a continuity from wherever you take the call from, and so on and so forth. E-prescriptions, for example, if he has to take a call from anywhere, he has to also have the process of creating the prescription from wherever he is, uploading it in such a way that it is available to the registrar in the hospital, it is available to the patient on his device, it is available to the hospital as a whole to maintain the medical records, and so on. So there are various factors which come into an EMR implementation when you look at its success, its adoption, and its cost. So I'm sure every hospital needs to have a kind of management focus, what they want to achieve, and therefore the cost factor is acceptable. I mean, that can be justified.
Yeah, but as a CIO, you will be having some budget that is allocated to you, right? So how do you manage that and justify? That was my question.
So if we know what is the kind of cost, we better budget for it first only. And when we have to, be it more or less, but when we have to justify it, definitely it's a challenge. And we have to define the pros and cons of that very clearly. We have to know what our hospital is driving at. If a hospital is always talking about digitization and becoming completely automated and all, then we know that it is more easier to justify the cost, because all these things do not come without a cost factor.
I think Arvind is too eager to take up this question.
Yes,
Yeah,
please.
Look, let's be very clear here that with digital technologies, this whole conversation around EMRs is becoming like electricity and water. Yes, there is a cost, but we'll have to also look at each of our organizations and the healthcare sector as such. What is it that we are facing? What is it that we are facing as problems in terms of adherence to quality, adherence to services that we are able to provide, the ability to live up to the expectation that we are a 24/7, 365 service organization, and the ability to ensure that we are able to do 24/7, 365 service at the highest level of precision and perfection. These are very, very important aspects of our larger organization, and thereby its impact on the cost that we have to spend, the investments that we will have to make in terms of people and manpower to see this through and ensure that it sees the light of the day. But bottom line, like the yesteryears where electricity and water were luxuries and were getting into various parts of urban and rural development, I would relate it to a similar situation that we are in. And after some time, it's a matter of fact, and you can't live without it. Telephones were a luxury. Mobile phones were a sense of a status symbol. I think today it's part of life, and there's benefit in it. There's been so I think the realization of that benefit and thereby finding the opportunities to translate that, working out innovative cost methods, and tying it to strict adoption, because by just buying some software and implementing it, you're going to get nothing. You're going to drain cost. So this is all the reason why you should not do something. Connect it to adoption. Look at it as an organizational initiative, and please don't look at it as an IT initiative. IT can deliver the outcome of clinical expertise, and IT is not qualified to deliver clinical expertise. With due respect to all my colleagues. We have a different set of expertise, and let's really not attempt to do something clinical on that. And bring it as an organization initiative. The value will be there. We will find the money. Money is not freely flowing, but I think those initiatives and thereby the ROI, those business models, those modified business models, I think that's really how you're going to find the money. Otherwise, nobody's giving it to you.
Agreed, Arvind. I think it should be an organizational goal rather than an IT goal of identifying a vendor and rolling it out. Very rightly said, only then it can be successful, and then the cost or the budget doesn't come in picture. Yeah. So coming back to Prashant, so can you give any case studies where you implemented and you've seen the benefits in treatment and all, how the doctors are happy with this? Any case studies you would like to highlight?
Yes, Girish, I would like to highlight few case studies actually. One is, as you know, that the biggest challenge is the implementation of OPMR specifically, when you have 40-50 patients waiting in your queue, and you are still heading towards the doctor to implement the OPMR. So then there's an alternative mechanism actually which we implemented in two of our group hospitals. So that is the use of electronic pen and a specialized paper basically. So we could successfully implement that particular project, so much so that we are getting the exact data feed also coming out of the same technology. And we are able to leverage that particular data set which is coming out of that, so much so that whenever the patient is just reaching the billing counter, the order, the investigation order is already ready, which has come from that particular technology, which has been handwritten by the doctor. And the accuracy, let me tell you, accuracy is up to the level of 90-95%, and it is increasing day by day. So that was one, actually we saw a very good use case actually from the technology standpoint, and specifically it is a balance between OP EMR and the digitization. So that was one part. The other part is the barcoded medicine administration, so which has been very in a good manner actually implemented in all across hospitals, and we are pushing this particular in rest of the hospitals also. So which takes care of the medication order from the doctor, barcodes the medicine actually which has been disposed by the inventory, and the patient band also. So it really working well in terms of reduction of the medication error. So these are two I just wanted to highlight.
Thanks, Prashant. Coming back to Vineet, now we see a lot of EMR adoption. So when do you think that there will be interoperability between two hospitals, not within a hospital, but if Aster wants to exchange data with Apollo or HN, so how soon would you see that?
Obviously, with the the National Health Registry, that is definitely the scope, and that is definitely the direction. And like all of us are trying to be part of it and doing our bit there. So that is definitely something that we look forward to. But even before that, I'm sure most of us are even struggling to ensure the data is available between our hospitals. So that I guess is a simpler thing for us to crack first. So ensure that we ourselves have our own uh, what is called health information exchanges. In India, I have in India our hospitals have been able to do that. In the GCC, in the UAE, like I said, there is a very clear direction from the government where there is the health information exchange is put in place. Uh, here the benefit is things are driven with a fixed date and the dates don't change. So there is no question of anybody missing those dates. So like Abu Dhabi has gone ahead with what is called as Malafi, where the hospital information are exchanged between all the hospitals. By end of this year, even the clinics will be part of it, and we as responsible providers will be part of the whole program. In UAE, there is something called as NABID, NABIDH, that also is on the same line. So most of us players are already part of the pilots, and that could be also another 6 months. There will be a system in place. So so these kind of initiatives cannot be that me and Arvind decide that let's start working on sharing data and it cannot work. It has to be done at a very different level, and that's the reason definitely welcome the whole national health registry and the projects that's coming in. We and as part of Chime, we are again driving that as part of Chime as well.
Okay. So any benefits in terms of revenue, are you able to translate or into this EMR? Or because we have seen the clinical benefits of having an EMR, but any revenue pointers can you give that this has translated into
Definitely.
revenue?
So it's like, yeah, so there is everything is interlinked. There is definitely no, so like I said, in this market where it's the payer market, the money is linked with the EMR. There is no thoughts there. It's all interconnected. The revenue cycle management, as we call it, uh, is linked from the time a patient registers, because we see what is eligible for, what is the exclusions, what are the inclusions, so that when the doctor is looking at you and treating you, he actually knows what that your insurance covers dental or insurance does not cover a dental procedure, whether your network allows the sonography or does not allow a sonography, and so on. So therefore, the EMR definitely guides you in the clinical decision support, and therefore it ends. But to answer your question, I see there's a lot of benefit in using EMR, more to manage the cost. So we'll all be under pressure. We like with the DRG, which is diagnostic related group. So with DRG and things like that coming across, again in this part of the world, DRG is being implemented. US has gone ahead and done DRG. I'm sure at some point of time, India will also we will also be looking at it so that the overall cost to the patients are optimized. I'll not say reduced and made zero, but because the cost of healthcare will be a focus. And when that happens, and when we as providers will be responsible for ensuring that we are treating the patient with the right quality but maintaining the cost, I don't think it can work without an EMR adoption, because
Okay.
EMR will then EMR2 and the tools will help you ensure that you are giving the patient the right medicine at the right price, so that the overall and at the same time I see benefits both ways. From the patient perspective, the cost to be optimized, the cost to be lowered definitely from what happens now. At the same time, the providers will also have an opportunity not to miss on various things, because there is a lot of opportunity there for the providers as well. Yeah, I would say, therefore, BMR goes on to get you better revenues. Another opportunity that I see is a whole lot of work happening around the data that is captured, because as of now the data is captured in bits and pieces. A proper EMR implementation captures the data across the journey, and each element of the data will help you a lot. Whether it is you call it the research, whether you call it coming up with better solutions for the patients, either way, there's a whole lot of benefit that may not be directly measurable and could be intangible at this point of time. But I'm soon we're all going to soon see benefits coming out of that as well.
Okay, thanks. Now, Arvind, coming back to you now, this EMR adoption and capturing of data has thrown a lot of challenge to the CIO as the security, data security and privacy. So, as a CIO, what would you like to advise your peers, like what precautions they should take regarding data security and privacy?
I think it's about design by security. So we need to build security into the fundamental enterprise design, and we need to be very responsible. Obviously, in our enthusiasm to get certain things going, we should not make obvious security mistakes. We need to be careful about it. Sometimes it's not intentional, but I think we just need to be responsible about it. And the other aspect is take the organization along with us, explain it across the organization so that people don't see security related design and policy enforcement as a barrier to digital technology adoption. Uh, so we need to be more articulate about the benefits, the risks that it has. Obviously, short term, long term, some solution, some problems don't have solutions other than workarounds. I think we're going to carry the organization with us. And fundamentally, I would return back to building it as part of the enterprise design so that it gets in as the DNA of the organization, and then constantly revisit it because I don't think it's set in stone. So it needs constant changes. It needs and be careful to the best extent not to make it a barrier for adoption. Uh, Security can't be tight. Security can't be loose.
Yeah, because that is one of the reasons why the adoption is not very resistance from the doctors. They are not sure whether the data will be misused, shared from the doctors. There was a challenge. I'm sure you must have
I
faced
think
that.
the openness, Girish, we need to be completely open and give them that comfort that it is done with the right intent. Walk them through just like a doctor walks us through the procedure that he is going to perform and gives us that confidence and reassurance. I think we need to reciprocate in a similar manner how a doctor is responding to a treatment protocol. I think we need to give them that sense of reassurance. We need to give them that guidance, and we need to stand by them and take their questions and not brush it aside. I think we need to be more communicative to the stakeholder community to get them to understand the importance and the seriousness of it.
So this is thrown this in the IT because now CISO has become a very important part of this. Previously, it was managed by the CIO, right? Now with so much of EMR adoption and other. So do you recommend every hospital also to have a CISO along with the CIO, or how is it?
Start with the role first. Obviously, everybody is going to be challenged on people, manpower, and costs. Start with the role, and depending on the 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 length or the depth of how much it gets into and how involving it gets into, start looking at a role, meaning a physical person, a full-time person. But I would say start with a role, then graduate into a committee-based activity, and then into a specific person earmarked full-time for it. That will give an organization the sense of how much, and thereby the justifications of it.
Okay. Now I think we just have 5 minutes to conclude. So I would request my fellow panelists if they want to say anything on the topics discussed before we go for a closing.
Actually, Girish, I just wanted to talk a little bit more on the cybersecurity piece, which Arvind was talking on. Just to add one more point to it, is that when we are talking about cybersecurity, we need to also understand that the control should be in our hands, meaning there are a lot of smaller players who are smaller nursing homes, hospitals, smaller smaller, standalone doctors and all who are adopting EMR, yet at the same time, they are going in for cloud-based systems. Cybersecurity, if that control is not that much in our control, basically the CIO or the IT head has to have that kind of control where we can build our own systems, we can build our own security, take care of our own security challenges, and build the the what do you call it? We are putting the systems in place, be it more cost or be it whatever, so that we can ensure the security of the implementation. That is not happening at all stage. Like if I have my own IT setup, if I have all systems on premise, that is more of a control in my hands, how I give the access to the hospital, than if I'm going on a public cloud, or if I'm going on a third party cloud, which is not completely in my control.
I'm not sure. I'm not sure there again. So it is. I believe. I believe cloud providers are equally safe. I would say that moving on to the cloud means insecurity. But if I
not always in certain situations, because there is a time when they keep on cutting costs in order to reduce the cost. That is seen in many cases. That from that point.
I would say we have to be careful as to who we go with. When you go with a software as service model, you have to be careful that the data is containerized or kept in a place where, because it could happen with small players. You could go with software service vendors and go on put solutions and patient data completely in the hands of a partner. There you have to be a bit careful. But what I have seen is, if you go with the trusted cloud providers, you're automatically getting a lot of benefit. By default, you're getting a lot of benefit. And some, to an extent, it saves you some of those trouble of managed service. So that's my experience. I guess it's a debatable part. Each one has its own choice. But yes, there is a possibility that at the end of it, responsibility is ours, right? When you say, just like you say, outsource doesn't mean you're outsourcing a responsibility. Outsourcing is only the process being outsourced. That's like that. You have to be careful that the data is.
Okay, thanks. Prashant, anything from your end you would like to highlight or anything?
Very quickly, I would like to touch upon the interoperability part, because the scenario which we are going to see from the NDHM point of view, so we'll all will witness a lot of interoperability thing coming in from the demand perspective also, or from the current instance perspective also. So maybe I think the next thing is adoption of the standards which can take us to the next level in terms of the adoptability. That is from my side.
Thank you. Vinith, anything from your side before we conclude? Because Pratibha is there. She's saying we need to wind up fast.
Yeah, nothing much. It's been a great discussion. Always great to connect with all the panelists. Anyway, know each other, and we've been in touch. But look forward to some of these projects. Like Prashant said, the National Health Registry is one of the big ones, and all of us will have a role to play in the EMR adoption as we go forward.
Yeah. So, if I want to conclude whatever, it was a great, insightful discussion, and I think when EMR adoption should come from the organization level, not an IT perspective, as we all agreed upon. So, cost shouldn't be a factor. We should see how this is going to help the organization to take care of the patients better in terms of catering point of care, or be it remote this thing. So this is really going to help. Secondly, we see EMR adoption being taking off very fast. There are a lot of government initiatives that have been done, and maybe when we are in the next discussion, it will be at a different level. Thirdly, as a CIO also should be geared up to understand what an EMR is, how to choose a proper solution, and then have a core committee, the team which would comprise of your not only the IT but a strong functional team, starting from the medical admin and other people. So I think thank you so much, Arvind, Vineet, Prashant, and Vilu so much. Thank you for a great discussion. Over to you, Pradeep.
Thanks a lot to you, sir, Mr. Girish, for taking up the moderation so well and asking right questions. And thanks for the delegates also who had posted questions. If there are more questions, you can always post it to us. We will be taking up to the speakers and get back to you. But live session can't go on. We have time limits. So thanks a lot for each one of you. This was the first panel discussion of the second edition of Healthcare Transformation Summit. I think it was a perfect start of the day. It was a very well-rounded panel discussion. I thank each one of you, and we will be doing more such editions. I will keep calling you all, and you please have to come as speakers. I'm just saying it in live session. So I'll just ask Mr. Deepak, can you please, we are giving speaker certificates. So thanks a lot, Mr. Arvind Sivaramatkrishnan, Group CIO, Apollo Hospitals, for taking your time, sir. It was nice having your inputs. Mr. Girish Kopar, General Manager, Wakad Hospitals, thanks a lot for the moderation, sir. Thanks, you are so good, the moderation. And Mr. Prashant Singh, the CIO of Max and BLK Hospitals, thanks for joining in, sir, and accepting the invitation and giving your thoughts as well. And Ms. Willu Williams, CIO Head Transformation Search in Reliance Foundation Hospital, thanks for being in the whole conversation, ma'am, not leaving in between. Thank you so much
It
for
was
that.
my pleasure.
And Mr. Thank you. And Mr. Vineet Purushothaman, CIO, Aster DM Healthcare. Thanks a lot, sir. You've always been a pillar of support whenever we call you come in. Thank you so much for it. So thanks a lot for the all the panelists. It was a great discussion. So looking forward for the same in the next edition of the summit as well. Thank you.
Thank you.
Thanks,
Thank you.
Pradeep.
Thank you,
Thanks.
everyone.
Thank you.